everybody. Welcome to Grand Rounds. So, as usual, we're going to get started with a brief presentation from some of our, in this case, faculty, about some of the work they're doing, and that'll be followed up by our guest presentation. So to start off, Dr. Stephen Wegner and Dr. Rachel Aaron are going to talk about their research, and they're talking about optimizing treatment sequencing for patients with chronic, non-specific lower back pain. So I'll let them speak a little, and then I'll come back up and introduce Dr. Wazotsky. Also, it's Resident Appreciation Week, everybody. So, as if you don't already, take a little time to appreciate our residents, because I know I do. That sounded weird. Never mind.
Good afternoon. Thank you for coming. On behalf of the Optimize team, I'm going to start off, and then Dr. Aaron and Dr. McGee will follow me, and we'll do a tag team on this whole project. This is a project that's getting started here at Hopkins and in a couple other sites across the country. We unfortunately do not have commercial disclosures. At some point, I hope to have a very long list of commercial disclosures, but I aspire to that, but I'm not there yet. So we're very quickly going to go over, talk about the rationale for this project, the study aims and outcomes, give you a brief overview of the study design, and then talk about the role of PM&R in this study implementation, because this study is taking place in our clinics, and you will be touched by it in some way or the other, right? Right. So this is taking place at 3 sites. At Johns Hopkins, the study PI is Richard Skolaski, a colleague of ours in orthopedic surgery, who many of you know. He apologizes he can't be here today. He had to be on the beach in Florida. And the lead PI is Dr. Julie Fritz, some of you may know, who's a physical therapist at University of Utah. And the site PI at Intermountain Healthcare is a guy named Gerard Brennan, who also is a colleague of ours as well. There's a very large research team here at Hopkins, including a number of folks, including Dr. Ariel right in the back, who's going to be leading the effort in the PM&R physician clinics. So if anything goes wrong, you know who to blame. All right, so the impact of low back pain, as this group well knows, that the most common type of pain and the most common reason for visiting a physician in the U.S. is low back pain. About more than 26 million people have low back, between ages 19 to 64 have low back pain. There's about 2.5 million people on disability for low back pain, which is, in my mind, a staggering number. It is the third highest healthcare spending category in the United States. First is diabetes. You probably can't read that. The second one is ischemic heart disease. But number 3 is back pain, and then comes hypertension. So we have a big problem, costing a lot of money, causing a lot of disability with significant expenses. So the issue is looking at non-invasive treatments for low back pain. There have been a number of research gaps we've identified in the literature and that are addressed by our project. The first one has to do is, what's the optimal sequencing for taking care of somebody with low back pain? Can we identify people who respond to different types of conservative treatment for low back pain? And can we evaluate the comparative effectiveness of different conservative treatments for low back pain? So, our goal is to examine common non-pharmacological treatments with evidence of benefit. As you know, PCORI only funds studies comparing things that are already in practice. They do not fund the evaluation or the investigation of new treatments. It only is looking at comparative effectiveness. Put another way, say it a more practical way, is in a PCORI study, none of the treatment is paid for by the study. It has to be something that's covered by insurance, or they will not study it. So that's in fact what we're looking at here, is established treatments. In this case, we're looking at a comparison of cognitive behavioral therapy physical therapy, and mindfulness-oriented recovery from low back pain. So let me tell you a little about the study design. This study design has 4 key parts to it. It's comparative effectiveness, we just talked about that, comparing 2 interventions that are used in clinical care. It's pragmatic, that is, this is not happening in a laboratory, it's happening in the clinic. Both our physician clinics, our psychology clinics, and our physical therapy clinics, right? It's adaptive, that is, the treatment responds to how people respond to the treatment. We'll show you that in a minute. And it's what they call a SMART design, which is sequential, multiple assessment, and a randomized trial. And you'll see how this unfolds in a minute. The purpose of this kind of design is to mimic clinical practice, okay? It's easy to design, hard to evaluate. But let me just walk you through the design a little bit. So somebody's enrolled in the study, they're then randomized either to evidence-based PT, They're randomized either to evidence-based PT or to cognitive behavioral therapy. Then, towards the end of that treatment, they are reassessed. If they're a responder, they finish out that treatment. So in this case, I'm assigned to CBT, I'm a responder, I get a little bit more CBT to finish that out, to provide maintenance to me. If I'm a non-responder, I'm re-randomized, either to PT or to mindfulness. The same thing is true up here. If I'm randomized to PT, I'm reassessed. If I'm a responder, I stay with PT. If I'm a non-responder, I get switched I'm re-randomized either CBT or mindfulness, and they're followed up at 6 months and 1 year, right? This is kind of how clinical practice goes. We pick a treatment, there's multiple choices. We start with one kind of treatment. We treat the patient. We then reassess them, and if not, then we try something else. We're only doing that in building randomization into it to take advantage of the power of randomization to study the phenomenon, to study the treatment. Pablo.
You define the treatment periods, 8 weeks or 10 weeks, or the 8 weeks after. Are people forced to receive treatment during those 8 weeks, or the dosing, or how much?
No, the treatment is standardized in those weeks, and we'll talk more about what the treatment is standardized to. But yes, the treatment is standardized. Everyone in this case is getting 8 sessions of treatment, either 8 PT or 8 psychology, or if they get to the mindfulness, they get 8 mindfulness, right? Okay, we're recruiting 945 people with non-specific low back pain, right? And we're providing some reinforcement to people for completing the questionnaires. We won't spend much time on that. In a study like this, the inclusion criteria you try to make them as broad as possible. It's a pragmatic trial. So anybody who's 18 to 60 before, who have low back pain based on this NIH 2-question screener, right? That is, you've had the pain for more than 3 months, and it's present for more than half the days, right? They have to have a healthcare visit for low back pain within the last 90 days, and they have to have at least moderate levels of pain. Okay? The only exclusions essentially are back pain red flags, right? We won't spend a lot of time on that. Or if they're knowingly pregnant, or if they've received one of these things within the previous 90 days. So you can't have had PT, just finished PT, and go into the study. You have to be free from treatment for either psychological care or PT for those days. And you can't have had lumbar spine surgery within the previous year. Okay. So the study outcomes, the primary outcomes are the Oswestry Disability Index, which many of you know, the ODI, which is level of disability, and the numeric pain rating intensity. These were chosen for 2 reasons. One, these are endorsed by the NIH task force as the main primary outcomes for low back pain care, and this is what stakeholders, patients, say is the most important thing to them. How much do they hurt? What can I do? That's what patients care about, right? We are setting a very high bar. You have to have at least a 50% improvement to be considered a treatment responder. Okay? Which is a big improvement. This is not tinkling on the edges. You have to be a responder or you are re-randomized. Because patients tell us, if I don't feel these 50% better, I'm not better. Right? The secondary outcomes are other aspects of health using a PROMIS CAT system. If people know the PROMIS system. If not, see me afterwards. And to measure depression, anxiety, pain interference, social role participation, and sleep disturbance. We are also pulling from the medical record health utilization data, including opioids and other back pain care services. And we're also tracking side effects of treatment. And now I'm stuck. The computer is thinking. Wonder why the computer is thinking. Everybody know what the PROMIS CAT is? Who was absent that day in PROMIS CAT school? PROMIS is the NIH system, the Patient-Reported Outcome Management Information System. These are questionnaires that have been developed by the NIH. They are online, and they use a CAT technology. That is computer-assisted testing. So we ask you a question. Let's use a simple example from spelling. If I ask you how to spell table, and you can spell table correctly, is it likely I need to ask you how to spell cat? C-A-T. No. The next word, if you spell table correctly, the next word you're going to get is going to be thorough, right? A word more difficult, and then by doing this, you can essentially use questions to ask 130 questions in 6 questions, right? So if I ask you if you can climb a flight of stairs, for example, if you can climb a flight of stairs, do I need to ask you if you can walk 20 feet? Probably not. So these things have all been standardized. PROMIS is a way of giving a large number of questions in a very short period of time, and the computer is still thinking. Okay, meanwhile, back at the ranch, we have these these interventions that we're going to compare. As we talked about, we're going to randomize you to PT or CBT. We're going to treat them within 30 days, treat them for 8 sessions and no more than 2 sessions per week. We're going to reassess and then re-randomize. Okay? So I'm going to let Terry talk a little about the intervention from the PT perspective, and Rachel talk a little bit about the intervention from the psychology perspective, and then we'll talk about what it means for the clinics. There you go.
Thank you. So from physical therapy standpoint, we have a smattering of therapists throughout the rehabilitation network that have been selected and gone through training so that we're standardized across. Each one has about a minimum of 1 year working with a persistent pain population, so this approach is not new to them. In looking at the total number of sessions, we have a minimum selected of 8 sessions that each patient will receive, but per the study, I think they can get up to a maximum of 10 before they'll be re-randomized. And our interventions will consist of education specific to chronic or persistent pain. In particular, we're going to utilize pain neuroscience education, therapeutic exercise, and then manual therapy. And our core emphasis areas is looking at a biopsychosocial model approach to our evaluation and treatment. So looking at this complex interaction of the biological, the psychological, and social factors that contribute to why this individual might have persistent pain, as well as pain neuroscience education. So really trying to get the patient to reconceptualize why they're in this persistent state of pain, and focusing on those maladaptive behaviors that have come about associated with that. And then our home exercise programs that we'll be prescribing to the patients are really going to help foster kind of a goal-oriented management, encourage self-management and problem solving, and utilizing both a graded exposure and graded exercise standpoint. So just to give you an idea of what the flow will look like, we'll evaluate the patients on day one, we'll intervene, we'll provide education, and then throughout the remaining 7 sessions, they'll get a combination of manual therapy, pain neuroscience education, and then the therapeutic exercise as well.
All right, so I'll tell you about our CBT and mindfulness interventions in 3 minutes or less. All right, so we chose cognitive behavioral therapy for one of our treatment conditions. Of the psychological therapies, CBT has by far the largest evidence base in terms of efficacy in improving pain-related outcomes in folks across a range of chronic pain conditions. So we chose a specific protocol to adapt that was developed for folks with low literacy in rural Alabama. So it's a neat protocol that really distills key CBT principles down into pretty digestible chunks for our patients. For both CBT and mindfulness, our providers are going to be mental health clinicians, so psychologists and clinical social workers who have at least a year experience working with patients with chronic pain. So in our CBT intervention, there are really 4 main areas of emphasis. Psychoeducation is a huge part of CBT, so giving patients information about factors that can influence pain, such as stress, thoughts, emotions, and behaviors. And then we begin to target some of these factors in our intervention. So we will give patients specific relaxation techniques to cope with pain and stress. We'll use behavioral activation, so teaching patients activity pacing techniques, SMART goal setting, to help them get physically active in a way that's safe, and also start to integrate some activities that are more pleasurable or enjoyable, things that often get lost when living with chronic pain. And then finally, the crux of CBT is this cognitive appraisal piece. So we'll help our patients notice thoughts that they have, maladaptive thoughts and beliefs that they have about living with pain, like, my pain will never go away, my life is over, I'll never get back to the things I love. We help them notice these thoughts and update those thoughts to be a little bit more realistic and a little bit more adaptive. So here you can see the course of 8 sessions. So our folks who meet our high threshold for responding to this treatment in the first phase will have the option of having a couple additional relapse prevention sessions. Otherwise, they'll be moved on to the next phase 2 condition. So I'll tell you a little bit about our mindfulness intervention. We've chosen a specific protocol developed by our co-investigator, Dr. Eric Garland, who's at University of Utah. He's developed this mindfulness-oriented recovery enhancement protocol, which is really has been developed with patients with chronic pain in mind, and similar to CBT, delivered by mental health providers with experience working with chronic pain patients. In our MORE intervention, there are 3 primary areas of emphasis. Mindfulness, of course, so helping our folks learn how their attention gets drawn to aversive experiences like pain, like negative emotions and negative thoughts, and learning how to reorient their attention back to something that's more neutral. So kind of a classic mindfulness intervention is using the breath to bring the attention back away from these more aversive stimuli. MORE also has a cognitive reappraisal component, so also addressing some of these maladaptive thoughts that we really know can help maintain a chronic pain condition, and gets at updating them in a slightly different way. And then finally, in addition to helping our patients take their mind off of those aversive stimuli, that pain, those negative thoughts and negative feelings, we also want to help them orient to positive experiences in their day. So we're doing some techniques to help them reorient their attention to really mindfully enjoy pleasant things that they encounter in their day-to-day. And then here we have the layout, and I'll pass it back to Dr. Wegner, who will talk about how this fits into our department.
Let me finish up in the next minute. The screening for these people will be done 2 ways. First of all, the study team will be looking at patients who are scheduled in our clinics, any MSK clinic, to see if they have a history of low back pain. If they do, they will get a questionnaire through MyChart, the 2-item NIH questionnaire, asked to fill that out. If they complete that, when the patient comes to you, that information will be in your record, and a BPA will fire telling you this person has chronic low back pain. We're asking you to make a referral to PT preemptively, because we don't know what they're going to be randomized to, and that keeps us from having to contact you. If they don't complete it in MyChart, the clinic staff will be notified that this person has low back pain, and we're going to use this as a way to launch tablet technology in our clinics. So the clinics will have tablets to give to patients. They will complete it, and it will go uploaded into Epic in real time. Once again, the BPA will fire. Also, as part of this, we're going to have back pain navigators who will be sending out the MyChart initiatives and helping these patients get scheduled for PT and get scheduled for psychology. And they will also follow them to make sure they make their appointments and do the data collection, right? So what's the role of our physicians? If you have a patient who has low back pain, you should be looking for the questionnaire, and it should be there with the BPA. If not, you can do it in Epic and ask the 2 questions, and it will score it and give you the BPA, right? Respond to the Epic BPA by making the preemptive referral to PT and encourage the patient to respond, because as soon as we see that BPA fire, a back pain navigator will call them and say, hey, we see you have back pain. Let's talk to you about back pain care here at Hopkins, right? So we think this has benefits for the department. It's going to improve the quality of care, people with chronic low back pain, increase our standardization and consistency, develop new capacities in guideline-based care, and it's going to help us build infrastructure about moving tablet technology into our clinics, which will put us in the 21st century. Thank you very much.